presentación, ya todos lo conocen, el doctor Firas Al-Niaimi. Le damos la bienvenida a este workshop de la maravillosa plataforma Nordlys.
Thank you. Okay, so good evening, everyone. Thank you very much for taking your time in the evening and coming to listen to me. And I want to thank ATM, Paula, thank you. Thank you, the organizer and the owner, for inviting me. And thank you, Dr. Patricia, for giving me the opportunity to speak yesterday. So I learned a few things about your country. It's the longest country in the world. The #1 producer and exporter of copper. Lapis lazuli, which I have here, and the highest number of sea lions as well. So I learned a lot about Chile and many things I didn't know. I didn't know that you were #1 in copper and the top 3 in lithium and #1 in lapis. So this is the beauty of traveling and knowing about different cultures. Right, so I'm going to talk about the Nordlys platform, which is this platform. How many of you have this platform? Okay. All right. Well, those of you who don't have, maybe you will be more interested in trying it. So it's really a fantastic platform, and I have it for a number of years, and now I use it almost every day. And you will see why, because there are a number of things that you can do with it. So it's called a platform, not a laser, and that is because we have different IPL handpieces. So every handpiece with a color is an IPL handpiece, okay? And the number is the filter. So we have different IPL handpieces, so we can do already a number of different things. We can treat vascular, pigment. They also have hair removal IPL handpieces. We have 2 non-ablative fractional lasers. So the numbers are the wavelengths, 1550 and 1940. So you already have IPL, 2 non-ablative fractional lasers, but it also has an Nd:YAG. So there is a lot you can do with one machine. And this is why it's become very popular, because it's good for investment. Instead of buying one Nd:YAG, 1 non-ablative fractional and 1 IPL, you have it all in one device. It also means you can do a lot with it. So I will start first with the IPL handpieces. And I think the most important part of this slide is we are different from BBL. BBL, essentially all IPLs are broadband, because all IPLs will have, filters extending to 1400 nanometers. So the definition of BBL, it's universal. All the IPLs technically have broad range. We are a narrowband IPL, or selective waveband technology. If you look at all the wavelengths, none of them exceed 950. So we cut off the water absorption. Because in the skin we have 3 chromophores, hemoglobin, melanin, and water. Water starts to be absorbed from 1000 nanometer. So when we have all these IPL handpieces with no water absorption, few things will happen. 1, we waste less energy, because when you have, imagine you have an energy light coming from an IPL handpiece. You want to target a vessel. The melanin will take some of that energy. The hemoglobin will take some, but the water will say, I want you as well. So you lose specificity for the vessel. Here, because we cancel the water, there's no water absorption, so the light is just going to be absorbed by the 2 main chromophores. And this is why it works much better. We don't need high energy, so we use 50% less fluence compared to the other IPLs. When we use 50% less, that means you can also treat skin type 3 and 4, with not high energy, and is less painful, and it's safer. So, narrowband IPL, not a BBL, a narrowband IPL, selective waveband technology, no water absorption. So, this is everyone else. Because after 1000 nanometer, there is no more hemoglobin absorption, there is no melanin absorption, and the only chromophore that is going to absorb the light is going to be the water. The water is in the dermis. The dermis is a swimming pool full of water, so we are going to heat the dermis. And this is when sometimes problems happen, because we use high energy, there's going to be a lot of heat, and it's also going to be uncomfortable for the patient. So Nordlys has a specific technology where they cut off the water absorption, because in the handpiece, water is circulating here. So as soon as the light comes from the flash lamp, it's going to be neutralized and absorbed by the water. And this is why it will only emit light up to 950 nanometer, which means, as again, it will just be absorbed by these 2 chromophores. The other unique thing about this IPL is that we can generate a very short pulse duration, 0.5 milliseconds. 0.5 millisecond, very, very short pulse duration. If you have diffuse redness, if you have poikiloderma, if you have post-acne erythema, you don't want a long pulse duration. You can use a very short pulse duration to quickly coagulate vessels, which also means you need low fluence. Many other IPLs, M22, for example, from Luminous, the shortest pulse duration is 3 milliseconds. So if you have diffuse redness, light pink, and a little skin type 3, first of all, you have water absorption, so that's problem number 1. Problem number 2 is your pulse duration is too long, 3 milliseconds, so you don't see coagulation, so they increase the fluence, and this is where problems happen. Here, we can use 0.5 millisecond or 1 millisecond low energy, and we get good coagulation. We can also split the pulse into 2 pulses. So half of the energy is in the first pulse, and the second half is in the second pulse. Or we can use a long pulse if we are treating, for example, visible vessels, telangiectasias. So if you see a patient like this, and I'm going to talk about myself, okay, because I want to make this personal. Few years ago, I would see a patient like this, and this is what I will say. I will say, okay, we will do V-beam for redness, then I will do Q-switch or PICO for the brown, then we will do non-ablative fractional. The patient will say, how many sessions? And how much is that? The patient will get scared and will walk away because I'm making it too complicated. Now, one word, Nordlys. The IPL handpiece is going to pick up on the red and the brown, and I see many patients like this. Many patients, if they are exposed to sun, skin type 2, 3, they will look like this. Okay, if you have aesthetic patients, you will have many patients like this. The IPL will pick up on the red and the brown, and if they want rejuvenation, you just add the non-ablative fractional laser handpiece. And you can do that in the same session. Okay, so you can see if I see a patient like this, I don't even need to think about other devices. It's going to be the Nordlys. And if you look very carefully also, this is just with the IPL, by the way. Just IPL. No non-ablative fractional laser, but also the quality of the skin improves. So the red and the brown is better, but the patients say also the quality of the skin improves. So you don't need the broad band IPL. Even with a narrow band IPL, you still get a lot of improvement because you're targeting the melanin, the hemoglobin. If you see lentigos like this, you can also treat very well because remember, this IPL handpiece is also starting with 555. So this means we cut off all the wavelengths shorter than 555. So this will be suitable for a slightly higher skin type. But you can also pick up on all of this. If you would treat this with a PICO or a Q-switch, you still will get results, but you probably will get a lot of frosting in many areas. And this is much faster, much easier with the IPL. It takes you 4 minutes. You just put the gel, you do 1 or 2 passes, and then it's much better. They will get darker, and then they will flake off. Even one simple lentigo, you can also just treat. You don't necessarily always have to treat the full face. It doesn't have to be the full face. So if a patient comes here with a lentigo, and if you don't want to invest in a PICO, and you just want to start with one machine, or maybe you give this treatment to your nurse or to another doctor, you just put gel here, you use the IPL handpiece. When you treat lentigo, use compression because you want to push away the blood so you lose the other competing chromophore. When you're treating redness, you just need to touch the skin. But when it's a lentigo, you press, so you push away the blood, and then the energy is just going to be absorbed by the lentigo. Okay, poikiloderma. We are dermatologists. If you look at the definition of poikiloderma, it's a mixture of vascular, pigment, and atrophy. So there's always going to be a mixture of brown and red. Some poikilodermas are predominantly vascular, some poikilodermas are predominantly pigment. I used to think pulse dye laser was the gold standard, but it's actually much, much better and faster to treat poikiloderma with an IPL. This is what I mean. Because you have diffuse redness, you don't see the individual vessels, you need short pulse duration. But also, this is neck. Neck is very unforgiving. It's very thin skin. It's prone to complications. So here we use short pulse, low energy, and you get very nice results. If you use other IPLs where you use higher energy, you have higher chance of complications. So for poikiloderma, I like to use the IPL. and I like to use it in a single pulse. Okay, so this is a patient from South Africa. He came to me, and he said, I have this problem. Can you treat? I said, yes, of course, IPL. He said, no, 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 no. No IPL. Look what happened. I had M22 luminous, and look, I have hypopigmentation. I don't want IPL. I said, no, no, please, trust me, one session. Because here, we just needed 1.5 milliseconds, 5 joule. And he said, oh, I can't feel the pain. But here, because they don't cut off the water, they have higher energy in thin skin, you can clearly see there's also melanin, it was just too much. So it is also much safer to use the Nordlys IPL system. Again, I used to think always that you only needed the pulse dye laser to treat port wine stains, but it's not the case, because here we can also get purpura. We can get a short pulse duration and we can get purpura. So once you get purpura, it doesn't matter if it was with a 595 or with an IPL, because here we can go to 1.5 or 2 millisecond, we get purpura and we get very nice results. Also, if you look at the handpiece, this is a large handpiece, so you get better, deeper penetration of the light compared to, for example, a 7 or a 10 millimeter round spot. So I have both, the V-beam, the pulse dye laser, and the Nordlys. For kids, pediatric cases, cases on the eyelids, I will use the V-beam. But for general cases, on the neck, on the face, I'll use a Nordlys. Faster, easier, no consumables. You don't pay for the cryogen, you don't pay for the dye. Again, if you look here, for example, these are there's purple vessels. So we know that they're large and deep. So we start with the VL handpiece. So this is the handpiece that starts from 555 to 950. So it goes deeper. And then when you're left with the pink vessels, you just use the PR530 because it's more superficial. So the PR530 handpiece, this one, this gives you light from 530 to 750. So what do we have? We have 532, a peak for KTP, 577, yellow laser, 585, 595. So this handpiece is very good for all things vascular because it has all the 4 peaks for hemoglobin. It also is a short wavelength, so it's also good for pigment. But when you have a dark skin, you want to go gentle on the pigment, or you want deep penetration, we use the VL555 because that starts from 555, so you don't need the 532, which is very superficial for the pink vessels. But it goes all the way to 950, so this will be the handpiece that we will use when you go deeper or darker skin types. So for those of you who have the Nordlys, I'll make it very simple in terms of the settings. There are only 3 parameters you need to know. That's it, only 3. Single pulse short, single pulse long, or double pulse. Single pulse short when you have to coagulate invisible vessels. When you just see redness, you don't see the individual telangiectasias. Poikiloderma, diffuse redness, rosacea, flushing, post-acne erythema, single pulse short. When you see telangiectasias, you have to coagulate, but longer pulse duration. Single pulse long. Everything else is double pulse. Everything else is double pulse. Acne, photorejuvenation, solar lentigos. If you don't know what to do, double pulse. Why? Because the double pulse, which is 2.5 milliseconds with a delay and 2.5 milliseconds, starting with 7 joule, is enough heat at enough time to give a biological response. You get protein denaturation, you get coagulation, you get heat generation, anti-inflammatory effect. So if you don't know what to do, double pulse. But there are only 3 parameters you need to learn. You look at a patient, what do I need to do? Is it vascular coagulation of invisible vessels? Single pulse short. Is it coagulation of visible vessels? Single pulse long. Everything else is double pulse. So if you look at this patient here, you clearly see that there is a purple component. So we start with a VL, and then when the purple improves, we are left with the pink, which is more small superficial vessels. We do the PR. Very nice results, no PIH. I don't need the pulse dye laser. I don't. You can just use this, and you don't have consumables. Can you see something in this patient? This is a patient of mine. If you look very carefully, you can see the round circles. Yeah, these round circles is the pulse dye laser, the V-beam having purpura. So she gets the purpura, she gets a very good endpoint, but is resistant. The port wine stain stays. She comes back and says, no change, because there are cases of pulse dye laser resistant port wine stain. Then I move to the Nordlys and look at the improvement. Look at the clearance. From here, the purple there is much, much, much better. And this has been published many, many years ago. IPL, which is this IPL, for pulse dye laser resistant port wine stains. 50% of the port wine stains that were resistant to the pulse dye laser, when they started using the Nordlys, they cleared. Why? Larger spot size, deeper penetration, different wavelengths, targeting different vessels. Okay? So let's show you how easy this is to use. This is a very, very simple device to use. All you need to know is the diagnosis and patient selection. But the actual treatment is very, very simple. Everyone will learn in 5 minutes. So if you have, for example, a port wine stain, you choose port wine stain. You select the skin type. You select if there is a tan, no tan. This is pink, red, or purple port wine stain. You choose pink port wine stain, single pulse short. The device is going to tell you need a short pulse because you need purpura. You can then change the pulse duration if you want. And you can, for example, go for a shorter pulse duration. Look, this you can change by an increment of 0.1 millimeter all the way to 0.5 millisecond. If you have the pulse, who has the V-beam? Who has V-beam? Pulse dye laser. You only have 0.45, 1.5, 3 milliseconds. You don't have anything in between. But here, if you fancy 2 milliseconds, 2.2 millisecond, 2.5 millisecond, you can do that. So it gives you a much better choice in terms of adjusting the pulse duration and the parameters. Let's move on to rosacea. Again, you see this. What are you going to choose? Are you coagulating the erythema? Single pulse short. Is it the inflammation and redness? Double pulse. But this is not going to be single pulse long because you're not seeing the visible telangiectasis. So it's very simple. Either single pulse short, single pulse long, double pulse. That's it. Only 3 parameters. And if you choose, for example, here, photorejuvenation is double pulse. If you go to acne, it's double pulse. So it is already the same thinking. Okay? With acne, works very nicely. The treatment takes only a few minutes. Another difference compared to the KTP, which I used also for many years, and the pulse dye lasers, the patient gets less edema. If you use the PDL or the KTP, they will be very swollen sometimes. Here, no edema. They will wake up the next day, little edema, a little bit of redness, but they can go to their work and do other activities. With the other lasers, there's more edema and longer downtime. Okay, parameters. Coagulation of vessels, but you don't see vessels. Single pulse short. Single pulse short. So 1.5 millisecond, 2 millisecond, boom. That's it. In lighter skin type patients, I like to do 2 passes. In higher skin type patients, only 1 pass. Of course, you always have to judge the patient. Is there tanning, no tanning? But typically, if you do 2 passes, you get better results compared to 1 pass. This is a patient who already had many treatments elsewhere, and she said, look, I only have this pinkness, and I want to get rid of this pinkness. 1 millisecond. 1 millisecond. So this is, let's choose parameters. You have 3 choices. Single pulse long if you see telangiectasias. We don't see telangiectasias, so it's not going to be single pulse long. You only have 2 other options. Single pulse short, coagulation of invisible vessels, or double pulse. Both will work, but you get better results when it's single pulse short. If you don't know what to do, you do double pulse, okay? But you can see the clearance of this very fine redness. This is the difference between Nordlys and the other devices. Because you can get a cheap IPL, and someone who's very red can end up like this. And the doctor will say, yeah, it's okay, it's good results. But the Nordlys will take it from here to there. This is the difference. Again, very simple, easy to show you. You choose rosacea. You select the skin type. No tan or tan. This is diffuse redness or inflammation. Diffuse redness is telling you single pulse short. You can also, if you want, you can go and adjust that. If the patient says, oh, I have a little bit of tanning, or you see a lot of redness, you just increase the pulse duration a little bit. Perfect. So this is a device for someone who says, I know nothing about lasers, teach me how to press the buttons, they can learn. Someone with a lot of experience who says, I want to play around with the pulse duration, brilliant. So it's for the beginner to the advanced. Acne. Actually, we have a patient with acne. Why are these spots red? Because there are vessels. When we talk about inflammation and acne, a lot of this inflammation is microvessels also. So there's vessels, but also there is the production of the protoporphyrins. The C. acnes bacteria produce protoporphyrins, which, as you know, absorb in the Sorey band between 500 to 600 nanometer. So using the IPL, the 530 handpiece makes sense because here we have 530 all the way to 750. So we have these 70 nanometer wavelengths that we can use. Very nice and easy. Of course, we have isotretinoin and we have many other treatments. But you can combine as well. Because let's face it, the times have changed. We no longer give 50 milligram of isotretinoin. They become very dry lips and headaches and nosebleeds. Very few patients. Many patients also don't want to go on many medication, but you can clearly put them on 10 or 20 milligram, use some Nordlys, or in combination with topical therapy. If you see 20 acne patients a week, at least half of them will be eligible for Nordlys. It just takes a mind shift in terms of, instead of everything being very medical, you can introduce at an early stage also the Nordlys, because it also helps clearing the post-acne erythema faster, and patients will be more confident and comfortable. So again, this is our examples of don't give me isotretinoin, don't give me toxins, I want everything natural, everything vegan. Well, this is natural, it's vegan, it's everything, okay? So, and you can combine. If you give any patient, you give them something like a salicylic wash, some nice skincare, and some tretinoin, and you tell them this has to, you have to use this for 3 months, otherwise the IPL will not work, they will get better. The only reason they don't is because they are non-compliant. They use it for a week, they get a bit of dryness, they say, oh, it didn't work. It's an international problem. So this works very well in combination, and I like to use it also for the post-acne erythema. This is the most important slide, because this is what I mean. Here you don't see the individual vessels. You don't. Here you start to see telangiectasias. If you measure this, this will be 0.1 millimeter. And you get larger vessels. So let's talk a little bit about physics. A little bit about physics. You all hear about the thermal relaxation time, right? And we have to match the pulse duration to the thermal relaxation time. So the thermal relaxation time is the square of the diameter of the vessel. So you pick the vessel, you measure its diameter, and the square of the diameter of the vessel is your thermal relaxation time. We have human eye, we don't have a microscopic eye. In a human eye, we can only see a vessel like this when it's minimum 0.1 millimeter. So let's calculate. 0.1 times 0.1 equals 0.01 in seconds. And when you convert that to milliseconds, it's 10 milliseconds. So it's the same principle with KTP, with Nd:YAG, with pulse dye laser. If you see a vessel, 10 milliseconds. If you see a vessel, 10 milliseconds. If you don't see a vessel, it has to be shorter than 10 milliseconds. So this is what I mean by single pulse long, single pulse short. Everything else, double pulse. Very easy. Now you don't even need to ask about settings. You just see a patient, you see vessels, single pulse long. You see diffuse redness, single pulse short. Anything else, or you don't know, double pulse. That's it. Okay? But of course, when the vessel is larger, the pulse duration has to also be longer. But you don't need to worry because the device is going to tell you. Because when you choose the parameters, it's going to tell you, are you looking at small vessel or a large vessel? When you choose large vessel, it's automatically giving you a long pulse duration. Let's move over to the fracs, the non-ablative fractional handpiece. We have two handpieces, 1550, deep in the dermis. Anything in the dermis. Collagen stimulation, cicatrice the acne, wrinkles, pores, 1550. The 1940 is very superficial. It's for the epidermis. Is epidermal, microscopic epidermal resurfacing. Tone, texture, glow, Korean glass skin, smooth skin, baby skin. I have photo shoots. I have a wedding. I want to look good. Combined with skin boosters, 1940. Everybody will look good with 1940. Everybody will look good with 1940. If you do a 90, if you just want to make someone happy, give them 1940. Seriously, you agree? The skin is going to be smooth. The light reflection is going to be nice. The makeup is going to sit nice. And this will give positive feedback to the others, and they will feel much better. So the 1940 is very good for everything on the surface of the skin. So why are these two different? If you look at the water absorption, at 2,000 nanometer, it becomes ablative. That's why we have CO2 at 10,600 and erbium at 2,940. So the 1940 is very, very close to 2,000. So it is sublative, just below ablation, microscopic ablation, very strongly absorbed by water. The 1550, less strong absorbed by water. So I'm going to give you an example. You can see with the 1940, the effect is very, very superficial. As soon as the 1940 hits the skin, the little water in the epidermis, because the epidermis has less water compared to the dermis, the little water in the epidermis says, I love you so much, because it loves 1940. So it will suck all the 1940. Very little 1940 left to go deep. So most of it is consumed superficially. The 1550, the water will say, I'm not that keen on you. So it will bypass the epidermis, because the epidermis has low water and there's already low affinity, low absorption to this wavelength. So it will let it pass through to the dermis. The dermis has more water compared to the epidermis, so it will go deeper. So the 1550 is deep. Anything that you have in the dermis, acne scars, rejuvenation. But when you are working on the surface of the skin, it's the 1940. If you are thinking about erbium YAG, if you are thinking about TCA chemical peel, if you think about having a cloth and rubbing the face, 1940. Okay? The other thing is, you have a scanner. And this, by the way, this is not a consumable. Look, this you can just detach, and you can attach again. This is just a roller, okay? The scanner's inside the device. You can choose 4 millimeter, 6, 8, 10, or 12 millimeter. Talk to the patient. Psychology. Madam, can I give you a mirror? You have a scar here and another scar there. I will use the 4 millimeter. I will use it on the individual scars. And then you will see me change the parameters. I will use the 10 or 12 and treat the whole face. So the 4 millimeter is good for a small scar, surgical scar, or a wrinkle. When you have a wrinkle, you go on the 4 millimeter and you treat the individual wrinkles with the 4 millimeter, and then you go to the 10 or 12 millimeter and treat the whole face. 1940 and 1550. But we use this mostly for the 1550 because of the scars. But if you have, for example, a small lentigo, and you want to treat that with a 1940, you can put it on 4 millimeter.
When you put this, because we haven't seen the when we can move this.
Here. This is the handpiece. Watch. And it scans. It's the scanner. You just choose here. This is the scanner.
Okay.
You choose it here. Yeah? So this is 12 millimeter, or you can go for a 4 millimeter. So for example, here, this is the 4 millimeter. This is for a scar, or for a wrinkle, or a stretch mark, striae. When you are treating a striae, you match the width of the striae to the scanner width. You can use a 4 or a 6 millimeter, okay? Another important thing, let's go back here. Okay, let's go back here. Can you see when you use the 4 millimeter, the spots are closer together. When you use the 12 millimeter, far apart. So when you are using the 4 millimeter for striae, you have to use low density. Otherwise, you get PIH. And I have seen a lot of PIH from colleagues who will say, oh, but I use 30%. Yeah, but 30% you already have coagulation close to each other. So you're going to get too much heat. So you need to actually use a low density. But when you are using the 12 millimeter, you can use a high density because the coagulation columns are separated from each other. Okay? So just remember, the smaller the scanner width, lower the density. Okay, so cicatrice the acne. I know you are going to do multimodal approach. Subcision, TCA cross, PDRN, salmon, whatever you want to put in, I know you're going to put in. But when it comes to the technology, energy-based device, okay, you do a CO2 on this patient. Look, in England, we have many Indian patients, many Pakistani patients, and many patients who are black. You do CO2, you do it on 1 or 2, one of them will get PIH, they will scream and cause a trouble. You never want to do it again. So when you see many, many patients, it's more safer and suitable with a 1550 because much, much less risk of getting PIH. They can still get PIH, but the chance and the risk is much lower compared to the ablative one. How do I treat? The individual scars go on the 4 millimeter, do 2 or 3 passes, and look for the volcano effect. So 2 to 3 passes, you see the erythema and the edema, and then you go on the 12 millimeter, low density, and treat the whole cheek. Who had the energy? 35 to 40 millijoule. Yes. No, I use the higher energy on the individual scars and then lower energy when I'm treating the whole face. So I will use 40 millijoule on the individual and then I will use something like 35 millijoule on the rest. Okay? Almost never less than 35 millijoule. So 35 millijoule is almost the standard. If I'm doing lips, maybe 30 millijoule is fine, but no need to go less than 30 millijoule. So 30 millijoule is your lowest, 35 millijoule is your standard, but for acne scars, you can go up to 40 millijoule. In some countries, you can go to 50 millijoule, in some countries. In my country, we can only go to 40 millijoule. So that is the maximum we can go with a 1550. 50 millijoule if your machine can give you 50 millijoule. In some countries, they put the maximum energy at 40 millijoule. 40 millijoule is maximum. In some other countries, 50. What is in Chile? 50, yeah. So if you have a very deep scar, low skin type, you can go to 50, okay? But typically, 40 millijoule will be very good. 2-3 passes, 4 millimeter, and you will see it will swell, and then you'd go on the 12 millimeter. You can stay on the 40 millijoule, or you can just drop it to 35 millijoule and do a few passes on the rest of the skin.
How many passes?
4 passes. 4 passes.
With the 12 millimeter?
Yes. Yeah. 3 to 4. 3 to 4 passes. Okay? Because remember, okay. Important, please. The number of passes depends on what you have chosen in terms of the density. If you choose, for example, 40% density, it's going to ask you to do more passes. If you're choosing 20%, it will show you to do less passes. So the number of passes depends also on what density you have chosen, okay? But typically, we will choose something like 25 to 30% density, okay? Pores like this, 1550. So here, for example, 35 millijoule is enough. So 10, 12 millimeter, 35 millijoule, 4 passes. 30. 30 is standard. Just do 30% density. On most cases, it will be fine. In a very dark skin, you can go down to 25, 20, maybe skin type 5, okay? But for most of you here, 30% density is fine, okay? Not a problem. Scars like this. First of all, the erythema. Single pulse short, single pulse long, or double pulse? Excellent. See, now you've become expert in Nordlys. Single pulse short, so you take this, you put it on 1.5 millisecond, 5.4, 5.6, boom, 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 one pass. You wipe off the gel. Then you put the 1550. This is very thick, 40 millijoule. This is a little bit thinner, 30, 35 millijoule. 6 millimeter, 3-4 passes, 3-4 passes, 35 millijoule. Then put it on 12 millimeter, drop it to 30 millijoule, 20% density, and do 2-3 passes everywhere, and look at the improvements. And from close up, perfect. No CO2, no erbium, no crusting. She can just the next day put makeup and go to school with no problem. But all it needs is just adjusting. High energy for the thick one, lower energy for the slightly thinner one. Match the scanner width to this, which you can't do with a Fraxel Dual. So the Fraxel Dual from Salter has large spot or small spot, okay? Large spot or small spot, and this is a consumable, you have to pay. You have to pay. Here, no consumable, free, gratis. So here you can choose 6 or 8 millimeter, and you can do as many passes as you want. But with a Salter, once you put it on, you are using the half-life of, or you have using the number of the pulses, so it's more a consumable. We usually say 4 to 5, minimum 4. Okay? And I think that is realistic, because if we say 1 or 2, some patients will get results, but many of them will come back and say, I still have scars. So with the 1550, as a general rule, 3 to 5 sessions, as a general rule. Of course, there are exceptions, but 3 to 5 sessions. With the 1940, 1 or 2 sessions will give very nice results. Okay? So 1940, 2 sessions. 1550, 3 to 5. Here, a little bit of pigment, erythema, and scars. Nordlys IPL, and 1550. So here it's flat, so here you can use 35 millijoule, or even 30 millijoule will still work. But you don't need the 40 or 50 millijoule because it's a flat scar, not a thick raised one. Okay. Many, when they treat this patient, will go on 10, 12 millimeter and will do boom, boom, full face. But if you actually just ask the patient and give her a mirror, what bothers you? She will say, well, this area doesn't bother me. This doesn't bother me. But can you see these scars? These bother me. If you have an erbium or a CO2, this is exactly what we do. You choose the scanner width, we go on the individual scars, and then we do the whole area. So we do the same with the 1550. You choose 4 or 6 millimeter, 2 to 3 passes on individual scars. Look for the volcano effect. It will become red and ooh, erythema. And then you go 10, 12 millimeter and do the whole face. And look, you get very nice results. It's very easy to use, no consumables, very simple to use. Okay? Now, this is the only non-ablative fractional laser where you can change the pulse duration. I repeat, this is the only non-ablative fractional laser where you can change the pulse duration. You cannot do that with Fraxel, you cannot do that with the other IPLs. What does that mean? If you actually look at the device, and you can come and look later, we always talk about depth. That's because we automatically just talk about depth when we talk about fractional. But we also have to consider the width of the coagulation column. So with this device, when you use a longer pulse duration, you have a wider coagulation column. When you use a short pulse duration, 1 millisecond, you use a very narrow coagulation column. What does that mean? That means this is a Russian woman, low skin type, deep atrophic scars in some areas. So I can go on a 4 or a 6 millimeter, use a long pulse duration, so I get a lot of coagulation and tightening effects. But when I have an Indian patient with the same scars, then I go on a 4 or 6 millimeter, but I use 1 millisecond. So I use a very short pulse duration. The coagulation column is going to be very narrow, low risk of PIH. So the same when you're treating striae. When you treat striae, first you measure, okay, 4 or 6 millimeter. You go low density. The next thing you have to do is go on the expert mode and choose pulse duration, drop the pulse duration. The coagulation column will be narrow, so you have the coagulation columns further apart from each other, less risk of PIH. No other fractional laser allows you to do that. No other one. You can do also lips, so you don't need the smooth lips or lip lace from Photona. You don't. You can also use this. So this here, 30 millijoule will be fine. You don't need 40 millijoule. 30 millijoule, 25% density, 6 to 8 millimeter, depending on how wide the lip is. 3 to 4 passes, you get very nice results. Will it last forever? Nothing lasts forever. Nothing lasts forever. But you can do few sessions. Okay, it maintains good level of plumpiness, but it's also good for those older women with very thin lips because it stimulates collagen and it gives more pinkness to the lip because you get also angiogenesis. So for these very white, thin, collapsed lips, instead of just filling them with a filler, here at least you blow life into the tissue and they become more pink because you get angiogenesis. So you get lips like this. Frax 1940. So this was one of the first patients who had the 1940. This is how an English woman typically looks like. So a little bit of brown surface. Remember what I said. Anytime you think, I want to wear a cloth and scrub all of that, think 1940. Okay, so she had 1940. Look at the glow. Look at the quality of the skin. Look at how healthy the skin is. She says, I keep looking at myself in the mirror because I like how smooth, how glowy, how fresh, how nice the skin looks like. And this is what you get with a 1940. I know some will say, oh, but I have pico, I can treat. Yes, you can treat pico with a pigment, but look at the glow. And you get this all with just one handpiece. You just use the 1940, you get rid of the superficial pigments, and you get the glow and the hydration. This is a patient who was living in Florida with a lot of sun damage. After a few sessions, it's getting better. Look, no one can fix this, but it's getting better. And she likes also how smoother the skin is, and you can see it's less dark, and overall patient is happy. So you see these kind of leathery skin, this severely photo-damaged skin. 1940 is very good for that.
Why did you choose 1940 if in the market we have 1927?
Because 1940 is better than 1927. Okay, 1940 has more power compared to the 1927. It goes also deeper. So in terms of how deep it goes all the way down to 270 micron. There is also a split phase study from Australia showing that the 1940 recovery is faster compared to the 1927 and is less painful. So the 1940 basically is a very good one because actually there is a very nice paper that is hardly ever read, that the strongest water absorption is 1935. So the 1940 is a bit closer to the 1935 compared to the 1927. 1927 is not bad, but the 1940 is excellent. And if you have used both, you will prefer the 1940. Yes? Yes, yeah. Because those... No, you can use the 1940 on the rest. It depends on what you are using it for. So, for example, for the patch stage of acanthosis nigricans, it works nicely. Okay, so patch stage acanthosis nigricans for photo damage on the décolleté, on the arms.
Without IPL?
No, you can also use IPL. You can use IPL. But when you use IPL on the body with the 1940, you have to use low energy. Okay, just use low energy. But these cases were just used with the 1940.
You have to lower the energy compared to...
Well, okay, so the 1940, your standard energy is going to be 10 millijoule. But on the face and a light skin type, when someone says, I don't mind being a little bit red and maybe a bit swollen, I go to 20 millijoule. Yeah. And a skin type 1 or 2, when they want 20 millijoule. Amazing results. There's actually a study from Konika Patel from Florida. There was a big difference between 10 and 20 millijoule in terms of the results, but also more importantly, epigenetics. Because one of the new things now about the 1940, which you don't have in the 1927, is the data on epigenetics. As you know, with epigenetics, we have the genes that become sleepy because of DNA methylation. With the 1940, these genes start to wake up and they start to be turned on. And when 10 millijoule was used versus 20 millijoule, with the 20 millijoule, there was much better epigenetics and awakening of these genes. Of course, there's a longer downtime, and you have more redness and potentially a little bit more swelling. But for those patients who can accept the downtime, the 20 millijoule is going to give them better result than the 10 millijoule. But as a general rule, because patients like, oh, I'm worried, swollen, 10 millijoule will work on everyone. So if you don't know what to do, use 10 millijoule. But if you have the suitable patient who's willing to have the downtime, a lot of photo damage, a lot of field cancerization, because that's another data from the 1940, that it also helps with the field cancerization, you can go 15, 20 millijoule. So the density are usually 30%. 25 to 30 in most cases. The only exception is if you want to almost ablate a flat seborrheic keratosis or a very stubborn lentigo. I go on a 4 or a 6 millimeter, I go to 50% and do a few passes, but it's almost going to ablate. That's the only time where I will go to 50%. Otherwise, 30%. Yeah. Yes. 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 10 millijoule. Yeah, 10 millijoule. Because look, below 10 millijoule, you will have very little effect. So there is no point in going to 5 or 6 millijoule. Also, because remember, we can't just rely on this. This is why it's important to do research and studies and histology. Because the last 2 years, there have been 3 studies on the 1940, on the epigenetics, but also on the energy and what happens to the tissue. When you're using 5 to 10 millijoule, very superficial and little effect. But from 10 millijoule, you start to see an effect. And with 20 millijoule, you see a wow effect, but of course, longer downtime. Actinic keratosis, 20 millijoule. 20 millijoule. Especially if it's thick one. But if it's just field dysplasia, 10 millijoule will still be fine. Okay? Yes? Yeah. No, you lower the density because the fluence is, on the décolleté, 10 millijoule will still be fine. You just lower the density. Maybe you'll go to 25 or 20%. Yes, and we were going to do that today. Yes, the light and brown will going to be the effect that you will do. So you will use an IPL first, followed by the 1940. I can see that there are many questions about 1940, which means you have it. So as a general rule, look, if you treat 10 patients and you just treat them at 10 millijoule, all of them will come back and say, I'm happy. They will. But if you have a skin type 1 or 2, Scottish, Irish patients with a lot of sun damage, and they will say, oh, I don't mind, swollen, 20 millijoule will give them a wow effect. If you're treating individual thick actinic keratosis, 20 millijoule, because you want that depth, which is 270 micron with a 20 millijoule, okay? But for everyone else, 10 millijoule will be fine. But when you go less than 10 millijoule, you don't tend to see a lot of results. So 10 millijoule is your standard. And you can consider going higher in the lighter skin type patients or those patients who are willing to have the downtime. Is that okay? Any other question? Yeah, it will work. It will work. It will give you 10 millijoule, 30%. That's what it will give you. And it will work. And it will work on everybody. But this is why we are in a workshop, because we want to exchange ideas and say, when can you do more? When can you do more aggressive? So I can tell you that there is data that when you go more aggressive, you are having better results when it comes to epigenetics. You're having better clearance of the field dysplasia and the brightening effect, but at the cost of downtime.
How long is the cost?
3 to 4 days. 3 to 4 days. Instead of 1 to 2 days. Actually, many patients the next day will be red, but by day 2, they're okay. Especially now we use all the exosomes and PDRN and the masks and everything else. The healing is much faster. But yeah, otherwise it's 3 to 4. So 1 or 2 days extra. Yeah.
And how many passes with 1940?
3 to 4. 3 to 4.
For actinic keratosis?
Well, actinic keratosis. So are you talking about the individual lesions? I usually do 4. 4 on the individual actinic keratosis. Yeah, and then just do 2, for example, for the whole actinic display, on the whole area. But if it's just actinic dysplasia, 3 to 4 passes. Yeah? Okay. Acne scars like this, look. Oh, I don't know why it's moving fast. You can see the PIH, and you can see the scars. So here you could just do the PR, the 1940, and now you can move on to the 1550. So the other combination things, because remember, look, are you in the private or are you in the hospital? Who's in the private? Yeah, okay. In the private, you have the same problem like you have in Inglaterra and other words. You have the 1940, but the doctor next door also has the 1940. So the patient will say, oh, you are expensive, I'll go there. So sometimes combining treatments makes you stand out a little bit more. What does that mean? That means you see a patient with many lentigos and sun damage, you can say, okay, look, we could do peak OA for the individual lesions. Here is a mirror. Show me the ones you absolutely hate. These ones, okay, mark, peak OA, and the full face 1940. Because the next door doctor doesn't have a peak OA. So now, look, this is reality everywhere. Now you have given a bespoke treatment to the patient. Pico for the individual lesions, 1940 for the full face. Or someone who wants lifting. Who needs lifting? Not someone who's 20. Someone who's 35, 40. So they have sun damage. They need a glow. So you give them a HIFU with 1940 on top. So sometimes when I'm doing HIFU, I give them 1940 complementary. I'll say if you have 2 treatments or 3 treatments with the HIFU, you will have one 1940 for free. It costs you zero money, $0, because there are no consumables. Skin boosters. Okay, I'm going to ask you a question. Una pregunta. If I bring 2 women here, one is 20, one is 60. 120, 160. Do they have the same amount of water in the skin?
No.
Who has less? But we treat in the same way. So, as the skin gets older and drier, these wavelengths need water to interact. So this is another way that you can say, okay, we prepare the skin with skin boosters, biorevitalization. The water content is increased. The fibroblasts are awake. Your extracellular matrix is much healthier. The laser is going to work better. 10 years ago, actually 11 years ago, 2015, I was in Moscow in Russia, okay? I was with a translation, listening to a Russian doctor, and he said, this is our protocol. Every patient, when we do rejuvenation, fractional, we have to increase the water content. We prep the skin, we call it biorevitalization. So I went to the Western ward, and I said, guys, this is what they do in Russia. Oh, the Russians are crazy. You're not listening to Russia. What is Russia? And now they're all talking about skin boosters and biorevitalization. This shows you how hypocrite some doctors are. So, look, it makes sense that sometimes when someone's skin is very dry, one is very mature, they will get better results if you prep them with the skin boosters. But also the 1940 is very good for cosmeceutical delivery because it creates cracks in the skin. This was after the 1940, and then when you apply a serum, the skin is almost very thirsty for the serum, and it absorbs it more. So, look at this mixed race patient, okay? Of course, you will give them the topical treatment, but with a 1940 and glutathione and topical tranexamic acid, they get very nice skin, nice glow and healthy. What is the next question she will ask? She's going to ask, is this going to last forever? No, nothing lasts forever. Nothing lasts forever. And she will say, will it come back? I usually say, you come back. So, you give them results like this and you tell the patient, every 6 months, 1940, as maintenance treatment. You only need 50 patients, and if all these 50 patients are going to come back every 6 months, your diary is already full. You don't even need to worry about marketing and getting new patients. So now, because I travel a lot, I don't have many new patients. It's just the old patients coming back, having every 6 months, 1940. It's very easy. You bond with them. They know you. They love the results. So it's very nice. So remember, I'm going to ask you, who works in private? Question. If every condition, every patient you see, you only treat once and you never see them again, is that a good business model? No, it's a terrible business model. Terrible business model. No, because, okay, you are in a city with 1 million people. Okay, 500,000 will look for treatments. There are so many doctors. You see them once and they disappear. Sustained, continuous growth of any business is in the repeated customers. The patients, when they see results, they are happy to pay and come back. Trust me, they are. They are happy. Give me results, I'll pay. So the idea is that you give them nice results, but you are also very clear in the communication. You come back in 6 months and you have maintenance treatments. So I do that with rosacea. I do that with rejuvenation. I do that with melasma. I'll say, look, I can get it better, but you'll come back in 6 months for maintenance treatments. 1940. So 1940 improves on the colors of the scar. We create channels in the skin. Then you can put bimatoprost, prostaglandin analog, twice daily for a week, and you get repigmentation. Okay, so a study by Konika Patel showed that you get that cracks and the separation in the dermo-epidermal junction for 5 days, which means you have a window after the 1940 for 5 days to maximize throwing the cosmeceuticals in. So 1940, 10 millijoule would be fine, 30%, and then twice daily bimatoprost. This patient came to me and said, I want this. I said, you need surgery. She said, no, I don't want surgery. I just want non-surgical treatments. So I said, okay, I will give you HIFU, but the skin is begging for 1940. This is a skin that says 1940. So I said, okay, I said, okay, I will do HIFU, but please, can I give you for free 1940? 10 minutes it will take you and no consumables. She came back, she said, I like the results, but I love how smooth and glowy the skin is. And now she comes every 6 months. Not for the HIFU, but for the skin. And sometimes when you are waiting 3 to 6 months for the HIFU to work, in 2 weeks they will see the results of the 1940, they forget about the HIFU. They already love you because of the 1940. So the 1940 really is a treatment that is very good for a glow, for smoothness of the skin, and for keeping patients happy. And if you look at the close-up skin, look at the improvement in the quality of the skin. Right, so this is my last slide because we need to start treating our patient. I will put this on, I'll keep this for a couple of minutes. Many times I go to conferences and doctors come to me and say, I have $70,000, $80,000, I want to invest, what shall I buy? It's a very difficult question. Because if you are in India and all you see is deep dermal pigment, you need a Pico. If you are in a children's hospital and all you see is port wine stain, you need vascular. But if you can identify many of these conditions in your clinic, then the Nordlys is going to be your best device. So if you do Botox and fillers, everyone will going to be a candidate for 1940, everyone. If you see acne scars, surgical scars, 1550. If you are a dermatologist and you see rosacea, acne, brown spots, port wine stain, then it's going to be the Nordlys. So this is why worldwide, most of the doctors who start prefer to have the Nordlys platform because it's easy to use, no consumables, quick to learn, and they can do many procedures with it and many treatments. So with that, we'd like to say muchas gracias, and we have a patient. Right, so need my assistance. Thank you. Thank you very much. We have a So do you want to prepare, please? I'll put this here. Right, so before we get our patient ready, are there any questions? Any questions before we start? Yes.
After the 1940, after the 1940, how long you wait to apply makeup? Because if the channels are open.
No, the channels are open. I mean, it's okay. I usually say to them, 2-3 days you can start using makeup. 2 to 3 days. Yeah. Sometimes patients have used makeup the day after, and only afterwards they tell me. I usually tell them 2 to 3 days. 2 to 3 days. Can you sit up, please?
Yes.
Okay. Just for our patients, as you can see, can I ask? Just un momento, por favor. Okay, so we have a patient with some inflammatory acne, okay, and some acne scars. The skin is a bit shiny because of the anesthetic cream. So what we can do here is we can do both hand pieces. We can do the IPL first, followed by the 1550. Right, so single pulse short, single pulse long, or double pulse? Double pulse, exactly. So it's going to be double pulse. It will start at 7. You can start at 7.4. We'll do one pass. And then we are going to do the 1550 because we are treating the acne scars. We'll look where the deep scars are. We'll choose the 4 to 6 millimeter. We'll do 2-3 passes on those scars. And then we'll finish off with a full face. Okay? Thank you. Can we focus on the screen? Yes. On the screen. Here. Sorry, just your back for the screen. Perfect. Perfect. Okay, so it's in Spanish, but I can try. So here you see acne. Okay, skin type 3. Yeah. No tan. And it's going to give you double pulse, 7 joule. Double pulse, 7 joule. Why? Because it's not single pulse short because we are not coagulating vessels. It's not single pulse long because we are not coagulating telangiectasia. It's something else. Something else is automatically double pulse, 7 joule. Okay? Double pulse. This, where is the... this is the first pulse. This is the second pulse. Yeah? So half the energy is in the first pulse, and the second half in the second pulse. Okay? So normally, skin types 1 and 2 between half a joule to 1 joule higher. Skin type 3, half a joule. Skin type 4, keep the same results. So here we can just go to 7.4. Okay? It's just experience. Okay, this is powerful light, so everyone needs to wear goggles, please. Yeah, and then the gel, please. Any questions about the parameters? Any questions about the parameters? For acne, because it's not single pulse short or single pulse long, it's going to be double pulse. Double pulse always starts with 7 joule.
Sorry, but how you put a voluntary double pulse, or is
No, automatic, the machine is good. Yeah, yeah. When you choose acne, it will give you double pulse.
yeah.
Easy. The machine does everything for you. See. Thin layer, thin, not too thick. Okay, so another thing. With M22, with BBL, with everyone else that we don't like to talk about, they tell you to put thick gel. Why? Because also gel is rich in water, and they have wavelengths that are absorbed by water. So it has to go through this gel and somehow neutralize. We are not absorbed by water. We don't need thick gel. We don't need thick gel. A thin layer of gel is enough, because all you want is no air between the handpiece and the skin. That's all. But you don't need a thick layer of gel, because we are not absorbed by water. When I treat, I'm going to say 1, 2, 3, and then shoot, because if you don't have goggles, I am not responsible for vision loss, okay? I am not responsible. See. Okay. Turn. Thank you very much. I'm going to treat also the neck, so just putting some of that gel there. Okay, so gentle compression. 1, 2, 3. All right? 1, 2, 3. 1, 2, 3. How's that? Good. Good. That's fine. Well, the patient already had numbing. Very good. And now we can go to the upper cutaneous lip. This can sometimes be a little bit painful. All right, turn your head that way. And now we'll go to this cheek. Has someone timed this? It literally takes less than 10 minutes. I just need to do the forehead and then we're done. The forehead, you can go back to 7 joules, just because the forehead, you get light reflection from the bone. 1 pass, because we are going to do 15-50. If I'm not doing 15-50, on the acne spots, I'll do a 2nd pass. And I will show you just how to do it. Okay, here we go. Because if you do 2 passes and 15-50, it will be too much. Okay, so you can open your eyes for now. Can I just get gauze with a little bit of gel? A little bit of gel on the gauze. Yeah, put on the gauze, gel. Okay, attention please. Attention please. The 2nd pass on the spot, you can customize it. You just put gel on the gauze. You put the gauze here. This is the spot. So you can treat individual spots. Oh, just... See, for example, this is a spot. You just want to treat the spot. So you protect the rest of the skin here. This handpiece is going to be absorbed by the gel. And 1, 2, 3. So you have just a small spot treating the individual spot. This spot here, 1, 2, 3. Okay, this spot here, 1, 2, 3. Because the rest of the energy is absorbed by the wet gauze. Okay? Right, you can remove. Clean the face, please. Now you can relax and take off the goggles, because with a 1550, we don't necessarily need the goggles. So, double pulse, single pass, because we are going to do 1550. Otherwise, like I showed you, you just take wet gauze. If this is the spots, you cover below the spot, and then you put the handpiece like this. So this part of the handpiece is going to be on the spot, and the rest is going to be absorbed. So you don't need too much heat on the skin. You can see the skin is getting red. The spots are getting red, which is a good endpoint. There is coagulation, cooking. Something's happening in these vessels. Okay? Everything needs to be dry. Yeah? I do, but they will get downtime. So I will do it for someone who will accept minimum 3-4 days of downtime. I will do it when they have wrinkles, scars, and a lot of photo damage. I do. Yes?
BL and PR.
Sorry, there's a question, so we can all learn. Yeah.
In the same session, did you use BL and PR?
PR and VL.
In the same session?
Yes. So you use the VL and the PR when you have, for example, a purple port wine stain with some areas that are red and pink. The purple port wine stain, VL. The red and the pink, PR. Okay? If you have rosacea with a lot of deep vascular, you can see it's very purple. I will do VL first, because going deep, and I will do my second pass with the PR. Okay? So in rosacea when it's purple, and in port wine stains. Right. So everything dry. Now, can we just maybe move that way? We can focus on the screen. Let's focus on the screen. I'm waiting until everyone is quiet. Right. Well, I appreciate that you haven't seen each other for a while, so you want to catch up. But don't eat time from my workshop, please. I have flown many hours. Okay, so I know you can't see it, but this is cicatrice d'acne. Okay, so we press this here. Skin type 3, no tan. And it's automatically going to give us 34 millijoule. As I said, 35 to 40 is fine. Look, with acne scars, I do 35 minimum, but in her case, she's a light skin, she has some deep scars, I'll go to 40. So we'll increase that to 40 millijoule. Okay. Okay, I want to show you. So can we focus on these scars, please? Do we have a bin? Okay, maybe on these ones here, on the temple. Yeah, it's a little wet. Or maybe sit up a little. Maybe sit up. Let's see if, and turn your head that way, please. Let's see if we can. Just focus on this area here. Yeah, it's atrophic scars, but what we're going to do, so for these scars, what we can do is first go on the 6 millimeter, because they are a little bit wide. We can also go on the 4 here. Okay? We go on the 6 millimeter and we do few passes. 3 passes on each scar to go maximum coagulation at the depth of the scar. And then we will finish off treating the whole area. Okay? So you can lie down. We can cover the eyes, please. So, can we focus again on the screen, please?
Looking for a
Volcano. Yeah, Guatemala. The country with most volcanoes. Hmm? Yeah, also you have volcanoes. Yeah. Yeah. Can we focus on the screen, please? Because I want to show you something. Very close. Or maybe come closer. Ah, perfect. Perfect. Watch what I'm going to do. We have, everyone looks at this. Profundidad. Okay, 790 micron, that's deep enough. We are in mid-dermis, so that's fine. You go to the expert mode. You press the expert mode. You see here, where is the clicker? Oh, it's in my pocket. You see it automatically always gives you 2.7 milliseconds. And when you click here, suddenly you get this one, which is the width of the coagulation column. Look, when it's normal, it disappears. You only have profundidad. But when you press expert mode, you get the width of the coagulation column. Watch what I will gonna do. Pay attention here. It's 350. I am going to 1 millisecond. You go to 1 millisecond, and look what happens. You have thin coagulation column. This is good for fototipos 5. Fototipos 5 and cicatrices, striae, because you want very thin coagulation columns, less risk of PIH. And watch what happens when I go to 6.7 milliseconds, which is the maximum that you can have. Oh, it goes even higher. Look, very wide coagulation column. If you have a very atrophic scar on skin type 1, you go long pulse and you cook the skin. It will be red and coagulated. Okay? Expert mode. You have it, but no one uses it. You can't do this with Fraxel Dual, with Otra, with M22. No, forget. Only with this machine. Only with this machine. So here, because we have atrophic scars, okay, I will go to around 3.5 milliseconds. Okay, so we'll go to 3.5 milliseconds. Okay, and I still have the same depth and a little wider coagulation column. So we'll put that at 6 milliseconds, okay, and we'll start treating.
But the energy,
No, the energy remains the same.
no, 44.
No, okay, but you have to, can we go back to here? You look at the depth, the 44 millijoule, but look, it's still, the depth is the same.
But the energy change, it's no problem? Since 30?
No, it's because it's per MTZ. It's per MTZ. Yeah, it just changes the way it calculates it, but it's the same depth. Okay? Right. 6 millimeter. No, 4 millimeter is the minimum. The width.
How can we say that now?
Here. Okay, can we go back on the screen, please? Go back on the screen. Okay. Go back on the screen. Okay. Right. Look. Here. Can you see 4, 6, 8, 10, 12? Very simple. You just touch. 4, 6. Yeah? That's it. Very simple. So we will go. Okay, here on the scar. Look. Uno, dos, tres. Uno, dos, tres. Uno, dos, tres. Uno, dos, tres. And then stretch here. Uno, dos, stretch. Tres. You treat the individual scars. And then we can go to the other side. This will take you only 5 extra minutes, okay? But the patient will be getting better results. 1, 2, 3. 1, 2, 3. Some of the scars are a little smaller, so you just go to the 4 millimeter. Is okay with you?
Yes.
No pain?
No.
No pain. Which anesthetic cream did you use? Which anesthetic cream? ATM.
Yes.
Which anesthetic cream? 10%?
Yes.
Okay. Okay.
For 1 hour.
And here. Okay. Camera. Sorry.
Yes.
Volcano. See? Coagulation. If you have OCT or if you have biopsy, whoa, a lot of coagulation here. The patient will get good results, look. Yeah? Can you see? Everyone happy? Maybe sit up, please. Maybe sit up. And just turn your head that way, maybe from a little distance. Just here. You can start to see. Can you see that? Maybe you can see it already here. You can see. Yeah? Okay. Lie down, please. So now, do you mind? Sorry, I can't. Yeah. We'll just cover. Yeah, we'll do. So now we treated the individual scars. Narrow scanner width, longer pulse duration for more tightening. We just now go on the 12 millimeter. Okay? And we will do the full face. 3, 4 passes. Is okay? Not painful? Yeah, that means you are going a bit fast, so you have to just go slow. Beep, 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 a lot of beep, beep, beep means you are very fast. When it doesn't have enough time to make the scanner, it will beep.
And the coverage, the density,
25%.
but it's with the passes the machine marks.
Yeah, which...
5 passes?
No, but no. She's already getting a lot of redness and erythema. So I will do just 3 passes on her. Because I already did few passes on the individual scars.
If you put 30%, you need all the passes,
Yes, to get 40%, to get 30%. So if you put 30% and the machine will say 4 passes, that means per pass, 7.5% coverage. If you do 2 passes only, you will have 15% coverage.
But if she's too red, you can stop.
Yes, of course. If she's too red, if she's too painful, like now I can see she's getting very good endpoint. But remember, we also treated with IPL and we treated the individual scars. But I can see the scars are really getting good coagulation. So this is after 2 passes. I will just do 1 extra pass and that's it. You don't need the 5 passes. But if you look at her skin, if you look at her carefully, here is fine and here is fine. But she just has some scars there. So it's always good to use the 4 or 6 millimeter on the individual scars so at least she can see results. Because otherwise, if you just do there, this will get better, but she will not see it. The patient will say, oh, I can't see difference. Patients want to see difference. They don't care about what happens, histology, no histology. They want to see difference. She wants to come back in 3 months with less scars. That's what they want. At least in England. And I'm sure in Chile also. Right, we will continue. This will be the 3rd pass on this side, and then we will go to the other side.
The next session is 1 month?
4 to 6 weeks. 4 to 6 weeks, yeah. In phototipos 4, 5, I usually do 6 to 8 weeks. In phototipos 2, 3, 4 weeks is okay. Okay, so this is 3 passes. Now we're going to go to the other side. Yes.
Do you think that we do only when the 1550 is not enough? Because I don't have the machine with IPL.
No, the IPL is for her acne. Yeah, the IPL was for the acne because she also has some acne.
You don't need for the scars.
Yes, just for the acne. We did it because she has also active acne. If she doesn't have acne and she only has acne scars, you only do the 1550. Welcome. But this is a good model because she has both inflammatory acne and acne scars, so we could show you to use both. Painful?
Oh, yeah.
On the right cheek? Hot? Caliente?
Yes.
Well, most of you have stayed, which is a good sign. Okay. Yeah, finito. You can put the Aquaphor, yeah. So, good endpoint. Swelling. You can see the edema, erythema. Once again, we did the PR, IPL, because she has acne. We then did 1554 to 6 millimeter volcano effect, 2-3 passes on the individual scars, so you know for sure the scars have been treated, for sure. And then 10 to 12 millimeter, you treat the whole area. So the patient will come back and will say, okay, I can see improvement in a scar. You can do only this. Other things you can do, you can mix PDRN with with PLLA, and you can use a small injection, and you go just underneath the scar and inject a little bit.
Mix what?
You can mix PLLA, polylactic acid, with PDRN, or yes, and you mix them, and you just do a little injection at the base. So we use Lenizna or Juvluk, which has HA and PDLA, or you can use Rijuran from Korea, South Korea, okay? And you just inject that underneath the skin, which will be fuel for the new collagen, because now we just generate heat. But the mitochondria is thirsty. They need the ATP to start working and stimulating more collagen. So we inject underneath. And all you need to do, you just you just stretch the skin, you go underneath, whoop, inject, whoop, inject.
You have to inject, or you can use the channels?
Okay, you can use the channels, but with the 1550, you only get edema. So if the particle is very small, it will go. But if the particle is big, like polynucleotide, it will not go. Exactly. Exactly. And also, when you inject, you're doing a little subcision. So you just go a little subcision.
It was after the neck.
After the laser. After the laser. Because when you do before the laser, you have water and your depth of penetration is a little different. But all you need to do is that. Yeah, when you inject is better because you can be more precise. You can just lift up the scar. So it depends on what you have, but we have something called Juvluk, which is HA with PDLA. So there is immediate lifting and biostimulation. So we mix that with PDRN, or you can mix that with NCTF from Filmed, and then you just inject underneath the scar. That's all. And you put Aquaphor, porque Eucerin is sponsor. So you put Aquaphor afterwards, okay? And we have Aquaphor, okay? Tomorrow I have a workshop with Eucerin, okay? So come. Another thing is, I saw that there is a stand for BioEffect. I really love BioEffect. What I do, they have hydrogel mask. I put it in the fridge. After the treatment, I take it from the fridge, I put it, the patient will say thank you, because it's cold, vasoconstriction, it will help with the edema and cools the skin down, and it will really take the heat away. If you really like the patient, I give the patient 2, and I'll say put it in the fridge every day for the next 2 days, use that. It costs $7 per mask, but I don't know how much you charge. If you charge $400, $7 is not a problem. So this is what I use. I use the BioEffect from Iceland. I put it in the fridge. I use it afterwards because it's cooling. I give 2 to the patient, and then use Aquaphor. Yes? For skin? Field cancerization. For field cancerization, it's the same treatment that if you have some actinic keratosis, you go on the individual areas, and you treat the whole area, but we use the 1940, not the 1550. We use the 1940. Yeah? 1940. Thank you very much. No, thank you.
Thank you.
Thank you. We can have a group photo. Yeah. Group photo, yes. Thank you. And thank you for the patients. Right. Una foto. Yeah, you enjoyed it?
Congratulations.
Thank you so much. Muchas gracias.